Let's go over the warm-up. The question asks you to categorize all these different drugs, which is definitely high yield. So the direct cholinergic agonists include carbachol, bethanechol, and pilocarpine. Then the cholinergic antagonists are atropine, ipratropium, scopolamine, benztropine, oxybutynin, and glycopyrrolate. The indirect cholinergic agonists, or anti-acetylcholinesterases, include neostigmine, ecothiopate, donepezil, and edrophonium. So a lot of these drugs end in the ending stigmine, such as pyridostigmine and physostigmine, but those weren't listed here. So be sure you know the rest of these. Then we have some sympathomimetics. So the one that stimulates all 4 receptors is epinephrine. Then you drop off beta-2, and that's norepinephrine. D1 and D2 more than anything else, that's dopamine. Beta-1 and beta-2 equally is isoproterenol. Beta-2 more than beta-1 is terbutaline. And alpha-1 more than alpha-2 is phenylephrine. And then the cholinesterase regenerator is pralidoxime. The alpha blockers are the zosins, so terazosin, prazosin, and doxazosin. And then the non-selective alpha blockers include phenoxybenzamine and phentolamine. Then for the beta blockers, the non-selective beta blockers listed here are propranolol, timolol, and labetalol. And remember, labetalol is both a beta and alpha blocker, but it's a much stronger beta blocker than alpha blocker. And then the beta-1 selective beta blockers include atenolol, esmolol, and metoprolol. Now we're ready to move on to the lecture.
We've already discussed osteoarthritis and rheumatoid arthritis, and now we're going to cover several other types of arthritis, starting with gout. Gout is very high yield for step 1 and level 1. Gout is at least a 4-star topic. Gout is primarily caused by hyperuricemia, which is high uric acid levels in the blood, and then the uric acid precipitates out as monosodium urate, or MSU crystals in the joints. We call it gout, but as you should be aware, there's a more descriptive name, monosodium urate crystal deposition disease. Those monosodium urate crystals then trigger an inflammatory response, and the joint gets acutely inflamed, becoming red hot and painful. So if you were to stick a needle into that inflamed joint and draw out some fluid, you could see these urate crystals under the microscope. The crystals are needle-shaped, so they are long, thin, and pointy. They are also negatively birefringent. That means that if you put a special filter on the light of the microscope, a special polarizing filter that filters out most all of the light except for the light shining in one particular direction, then the crystals that are parallel to the direction of that light are going to look yellow. You can remember that the L's in the word yellow are 2 parallel lines, so these crystals look yellow when they are parallel to the direction of the polarized light. The other MSU crystal in this image is perpendicular to the polarized light, so it looks blue. The most common reason for someone to have high uric acid levels is decreased excretion of uric acid in the urine, often because they're taking a thiazide or a loop diuretic. However, high levels of serum uric acid does not always result in gout exacerbations. A relatively small number of people have a high uric acid because of increased production of uric acid. There are 3 scenarios of excess uric acid I want you to remember. Eating too many purine-rich foods such as anchovies, sardines, kidneys, liver, or sweetbreads. If you don't know what sweetbreads are, sweetbreads is a name given to dietary thymus and pancreas. The second scenario is Lesch-Nyhan syndrome, and the third scenario is leukemia or lymphoma, where the treatment causes increased cell turnover and tumor lysis, and that lysis of cells can induce excess uric acid. Clinically, gout presents with asymmetric joint inflammation. So instead of several inflamed joints in both hands, like with rheumatoid arthritis, with gout, you may have one inflamed joint here, one inflamed joint there, and so the pattern of joint involvement is asymmetrical. And it's usually just one joint at a time, which is different from both osteoarthritis and rheumatoid arthritis. If you have inflammation in a bunch of joints, such as in rheumatoid arthritis, we call that polyarthritis. If it's just one joint at a time, such as in gout, it's monoarticular arthritis. Or if we're talking about a few joints, a small number, but more than one, that's oligoarthritis. But gout is usually monoarticular, one joint at a time. The inflamed joints in this image are swollen, red, and exquisitely painful. And the most classic joint involved is the first metatarsophalangeal joint, the big toe, and the name for this inflammation in the first MTP is podagra. That just means there's an acute flare of gout in the first MTP joint. You can also see tophi, which are masses of urate crystals either on tendons or on the ear or on the olecranon bursa. Tophi are not inflamed or tender, they're just masses of urate crystals under the skin. Gout tends to be cyclical, so it flares up, then it cools down. Patients with gout don't have that red, hot, painful toe all the time, it just comes and goes. Some patients have flares with great frequency, and some have very rare flares. If they have an attack of gout once a year or less, there probably is not a need for that patient to be on acute gout drugs. If they were having attacks more than once or twice a year, they're probably going to need an anti-gout drug treatment regimen. So what kinds of things precipitate an acute attack of gout or flares of gouty arthritis? Flares can result from dietary excess or after excessive alcohol consumption. The mechanism of alcohol-induced gout exacerbation is worth knowing. Alcohol metabolites compete for the same excretion sites as uric acid in the kidney. The kidney has to choose between excreting uric acid or excreting the metabolites of alcohol. And like I said, most patients with gout have elevated serum levels of uric acid, but the serum uric acid level does not predict gout. You can have acute gout without elevated uric acid, and you can have elevated uric acid without having gout. The serum uric acid level is a useful clinical clue, and it may influence your choice of medication for treatment, but it's not diagnostic by any means. Let's talk about the treatment of gout, which is also high yield for your test. We treat acute gout and chronic gout with different drugs. Let's talk about the treatment of acute gout flares first. One of the classic acute gout drugs is colchicine. But here's where I'm going to teach you what you need to know for the test, then I'm going to teach you what the real-life application. So for the test, colchicine is a classic drug used for acute gout exacerbations. You might recall colchicine as one of the drugs that inhibits microtubules. Colchicine works by binding and stabilizing tubulin to inhibit the polymerization of tubulin, so it impairs leukocyte chemotaxis. The inflammatory cells can't get to where they need to go, so there is less inflammation. Colchicine is known for its GI side effects, particularly diarrhea. We used to give a dose of colchicine every hour until the patient either got better, developed severe diarrhea, or reached the maximum dose of the medication. Now the current recommendation is that if you're going to use colchicine, you just give 2 low doses, and that seems to work about as well as the old scorched earth regimen. Colchicine has a fairly low therapeutic index, which means there's not much difference between the therapeutic dose and the toxic dose. It doesn't take much colchicine to cause toxicity because a lot of your body cells need working microtubules. If you inhibit those microtubules, you can get pretty sick, and excess colchicine ingestion can result in death. So for that reason, NSAIDs instead of colchicine are going to be the treatment of choice for acute gout, at least on your test. You may use any NSAID, but indomethacin is a classic NSAID used for gout, and indomethacin is probably the best answer on your test for the treatment of acute gout. But in the real world, you might use NSAIDs, but most doctors I know just give a short course of steroids instead. You give oral steroids for 4 or 5 days, and these patients feel much better very quickly. So that's the treatment of acute gout flares. What about treating chronic gout? So the patient had an acute flare, and you got the flare under control with steroids or indomethacin, and now you need to control the uric acid level so that you can prevent future attacks of gout. And there are a couple of different strategies to prevent acute flare-ups of gout. One strategy is to increase renal excretion of uric acid using probenecid. Probenecid works by inhibiting reabsorption of uric acid in the proximal convoluted tubule, which means that more of the uric acid is going to stay in the urine and get excreted. As a side note, probenecid also inhibits secretion of penicillin. So in World War II, when penicillin was in short supply, they were able to conserve penicillin by giving probenecid along with lower doses of penicillin. The other strategy for lowering uric acid levels chronically is to reduce uric acid synthesis. The main drug that does this is allopurinol. Allopurinol inhibits the enzyme xanthine oxidase. Xanthine oxidase is responsible for converting xanthine to uric acid. So if you aren't making as much uric acid, you might have less gout. And there's another much newer drug called febuxostat that also works by inhibiting xanthine oxidase. So these two drugs, allopurinol and febuxostat, are particularly effective in patients with gout due to high uric acid levels. So to recap, for acute gout, for testing purposes, you're going to start with an NSAID, usually indomethacin, and then colchicine would be a second-line drug, but in the real world, you would use steroids such as prednisone first line. And then for chronic gout, allopurinol is used much more commonly than probenecid. Maybe if they give you a clinical scenario in which they specifically tell you that the patient has very low uric acid levels in their urine, so they're under-excreting the uric acid, maybe then they want you to pick probenecid. Also, low-dose colchicine can be used for the management of chronic gout, but for the most part, allopurinol is the go-to drug for managing chronic gout. So let's talk about pseudogout, which is obviously very similar to gout. It's just a different crystal that you're dealing with. Instead of the monosodium urate crystals, you're dealing with calcium pyrophosphate crystals. You might use the P in pyrophosphate and the P in pseudogout to keep them straight, if that helps. And then the official name is calcium pyrophosphate deposition disease. In pseudogout, instead of needle-shaped crystals, there are rhomboid-shaped crystals, and they are weakly positively birefringent, which is another P word. Pseudogout, pyrophosphate, positively birefringent. Remember, the urate crystals were negatively birefringent, so they were yellow when they were parallel in the polarized light. But the rhomboidal calcium pyrophosphate crystals seen in pseudogout are weakly positively birefringent and are blue when they are parallel to the polarized light. But when they are perpendicular to polarized light, they look yellow. Pseudogout usually affects the large joints, classically the knee, and it affects older patients over 50 years old, often over 60 or 70 years of age. Then treatment is basically the same as gout as well, steroids or NSAIDs or colchicine. Then one other thing I want to mention with pseudogout is something called chondrocalcinosis. Chondro means cartilage and calcinosis means calcification. This is calcification of the articular cartilage. If you see an x-ray of the knee with these thin lines of calcification along the cartilage, especially in the meniscus, that suggests pseudogout. Now let's talk about the seronegative spondyloarthropathies, which is a group of disorders that are associated with arthritis, especially arthritis of the spine, which is where the word spondylo comes in. Spondylos is a Greek word for spine. But the rheumatoid factor in these disorders is negative. With rheumatoid arthritis, you have that positive rheumatoid factor, but not with the seronegative spondyloarthropathies. And these disorders have a strong association with HLA-B27. And the mnemonic for these HLA-B27 associated diseases is PAIR, P-A-I-R. P is for psoriatic arthritis, A is for ankylosing spondylitis, I is for inflammatory bowel disease with the associated arthritis, and R is for reactive arthritis, and the old name is Reiter's syndrome. All right, let's talk about psoriatic arthritis first. I'm not going to say a whole lot about psoriatic arthritis. It's a form of inflammatory arthritis associated with psoriasis. Psoriasis is a disorder of the skin that is characterized by skin lesions that are scaly plaques or papules that are classically described as having a silver scale. The arthritis is often asymmetric, just like the psoriasis is asymmetric and patchy. But psoriatic arthritis can also be very symmetrical and can look an awful lot like rheumatoid arthritis. Psoriatic arthritis often affects the fingers, especially the DIT joints. It can also affect the spine and sacroiliac joints. Remember that rheumatoid arthritis affects the MCP joints and PIP joints. You can have dactylitis, and that is inflammation and swelling of the fingers, which is occasionally referred to as sausage fingers. And x-rays of the fingers may show bony erosions that we call pencil and cup deformity. Only about a third of psoriasis patients will actually have the psoriatic arthritis. So you can have psoriasis without any arthritis, or you can have psoriatic arthritis without any psoriasis, although that's less common. You can have both psoriasis on the skin and the arthritis. The next one is ankylosing spondylitis. Ankylosing spondylitis is a chronic inflammatory disease of the spine and in the sacroiliac joints. Spondylitis means inflammation of the spine, But make sure you remember sacroiliac joints, because anytime you see sacroiliitis or inflammation of the sacroiliac joint on your chest, one of the first things you should think about is ankylosing spondylitis. If there is chronic inflammation of the spine, this can result in ankylosis, where the joint starts to fuse. You can have fusion of the SI joints or fusion between the discs, or sometimes fusion in the facet joints. You can actually see what we call a bamboo spine on X-ray. So instead of the normal light vertebrae and then dark intervertebral discs, you can see calcification and mineralization along the intervertebral discs. The spine, in cases of ankylosing spondylitis, looks like a stick of bamboo. A bamboo-like spine is obviously going to limit spine mobility quite a bit, which is a classic feature of advanced ankylosing spondylitis, reduced spine mobility. And the stiffness of the spine and sacroiliac joints tends to improve with exercise. This is typically a disease that begins in young adulthood in the 20s or 30s, and a lot of these individuals will get up early in the morning and go work out or go for a 5-mile run, because that helps reduce the stiffness so that they can function during the day. Ankylosing spondylitis is associated with uveitis, inflammation of the vascular layer of the eye, and there's an increased risk of aortic regurgitation and conduction abnormalities and cardiovascular disease in general, such as peripheral vascular disease and even congestive heart failure. Then there is the I in the paramnemonic, which stands for IBD, inflammatory bowel disease, and they're going to be covered elsewhere in the lecture, but ulcerative colitis and Crohn's disease can both have an arthritic component, a spondylitis or a polyarthritis. Then there's reactive arthritis. This is a form of arthritis that typically comes on following certain infections, typically either chlamydia or gastrointestinal infections, classically Shigella, but also things like Salmonella, Yersinia, Campylobacter, and maybe Clostridium. So the patient had the infection, and then later they got a reaction to that infection, so it's a reactive arthritis. And the classic triad of reactive arthritis is conjunctivitis, or maybe uveitis. The second component of the triad would be urethritis, and the third component would be arthritis. The classic mnemonic is can't see, can't pee, can't climb a tree. Again, those 4 diseases, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease associated with either spondylitis or polyarthritis. And then reactive arthritis are the seronegative spondyloarthropathies, and these are more common in patients with HLA-B27, especially men with HLA-B27. Then to treat these, in general we start with NSAIDs or possibly some steroids acutely, and sometimes you use those disease-modifying anti-rheumatic drugs, or DMARDs. And the TNF-alpha inhibitor drugs are very important in treating those seronegative spondyloarthropathies. So let's talk about those TNF-alpha inhibitors for just a moment. TNF-alpha is a cytokine that induces the immune system, and the TNF-alpha inhibitors are drugs that bind to TNF-alpha and prevent it from activating the immune system. These drugs do suppress the immune system some. There are several available TNF-alpha inhibitors, although there are more being developed all the time. There's etanercept, infliximab, adalimumab, golimumab, and certolizumab. You can tell by the suffix MAB that the last 4 are monoclonal antibodies. They're antibodies against TNF-alpha. Etanercept is a little bit different. It's actually a recombinant TNF receptor that gets infused, so it acts as a decoy to bind up all the TNF in the body. Each of these drugs has a very specific FDA-approved use, but they all get used off-label as well. You don't need to memorize the specific indications for each drug. Just know that in general, they're used for rheumatoid arthritis and for these seronegative spondyloarthropathies. Then the other important point about these drugs is that since they are inhibiting the immune system, they carry an increased risk of infection, especially reactivation of latent tuberculosis. So we check a PPD, a TB skin test, before starting any of these drugs. And let's talk briefly about a type of arthritis called juvenile idiopathic arthritis. It used to be called juvenile rheumatoid arthritis, or JRA, but they've changed the name to JIA, juvenile idiopathic arthritis. JIA is a disease of children characterized by onset, usually before age 10, The classic feature is persistent joint swelling caused by thickening of the synovium and accumulation of synovial fluid. There are 3 types of JIA. There's polyarticular JIA, which is characterized by severe symmetrical arthritis, and the inflammation of the fingers is called dactylitis. Then there's pauciarticular JIA. Pauci means few, so instead of a bunch of joints being involved, this just involves a few joints, typically the large joints, but it almost never starts in the hips. And about 20 to 25% of those kids also get uveitis. And the 3rd type of JIA is called systemic onset JIA, and the old name is Still's disease. These patients can have arthritis, but they often have systemic symptoms such as fever, rash, elevated white count, anemia, hepatosplenomegaly, and lymphadenopathy. If they have all of these systemic symptoms, but not much in the way of obvious arthritis, JIA can look a lot like leukemia or lymphoma. Then one last important form of arthritis is infectious arthritis or septic arthritis. Septic arthritis can be caused by lots of different bugs, but the most common ones are Staph aureus, Streptococcus, and Neisseria gonorrhea. Gonococcal arthritis is an STD that presents as a polyarticular migratory arthritis with an asymmetrical pattern. The classic test scenario is a young sexually active person that has a swollen, painful knee. That's more likely to be Neisseria gonorrhea in that clinical scenario than anything else. Gonorrhea can cause synovitis, tenosynovitis, and pustules on the skin. How do we diagnose septic arthritis? You need to do an arthrocentesis. If you have any suspicion of septic arthritis, you have to stick a needle into the joint and aspirate some fluid. The fluid is basically pus, and when you look at it under the microscope, you will see a ton of white blood cells, and you might see some bacteria as well. And the reason you have to aspirate the joint is that septic arthritis can be really destructive, and if you find septic arthritis, you need to start IV antibiotics right away and get an orthopedic surgeon to clean out the infection. So that's it for joint diseases. Now it's time for the end of session quiz. So go through those questions on your own, and then we'll answer those questions together. All right, first question. What medications are used in the treatment of acute gout exacerbation? NSAIDs like indomethacin, or even run-of-the-mill ibuprofen or naproxen. You can use colchicine or you can use steroids. What drugs can be used in the treatment of chronic gout? Allopurinol most often, probenecid occasionally, or you can use colchicine or NSAIDs long-term if you choose. A sexually active 19-year-old man presents with pink eye, arthritis of the right knee, and dysuria. What is the most likely diagnosis? So a sexually active patient with acute arthritis of the knee and possibly some urethritis make you think about gonorrhea and gonococcal arthritis. And this patient also has conjunctivitis, pink eye. So this is probably a reactive arthritis. Can't see, can't pee, can't climb a tree. Remember the mnemonic and the triad associated with reactive arthritis. So that's it for this quiz. Now look at all the rapid fire facts. Go through those and then we'll cover those together. A swollen, red, acutely painful great toe joint would be podagra, seen in gout. Positively birefringent rhomboid-shaped crystals would indicate pseudogout. Negatively birefringent needle-shaped crystals would indicate gout. Bamboo spine on X-ray is a buzzword for ankylosing spondylitis. HLA-B27 is seen mainly in the seronegative spondyloarthropathies where there's a negative rheumatoid factor. And those were psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease arthritis, and reactive arthritis. Pencil and cup deformity on X-ray of the finger is psoriatic arthritis. All right, so that's it for this video. See you next time.